Hi, everybody. I am Beth Fields with Liberty Home Care and Hospice, and I have with me today Helen Martin, one of our palliative nurse practitioners, who will also have a lot of good information for you. So I'm actually going to let Helen start. We are going to give you information on what palliative is and how it can benefit a patient and their families. And also what hospice is and how hospice can benefit a patient and their families, and kind of compare the two and clear up any misconceptions about the two, and just give a little bit of an idea of which one is right for certain types of people. So I'm going to turn it over to Helen Martin.
Hi, I'm Helen. I'm a nurse practitioner and I work in palliative care. I was a hospice nurse for 12 years before getting my master's degree at Creighton University in Nebraska, and wanted to keep my focus on end-of-life care. So anybody here from Nebraska? Darn, that's always kind of an icebreaker. So usually I don't see anybody from Nebraska. All right. So how many people are familiar with palliative care? Okay, so several. And how many people are familiar with hospice? Good, okay. Because a lot of times we'll go into a situation and people think that palliative care is the same as hospice, okay? So hopefully today I'm just going to run through a quick rundown of the comparisons. During our Beth and I talking, take notes, and then at the end of the session, then we can answer any questions that you have, okay? So while the objective of palliative care and hospice is symptom relief, the prognosis and goals of care tend to be a little bit different. So hospice is comfort care without curative intent. The patient no longer has curative options or has chosen to not pursue them because the burden outweighed the benefits at that time. Palliative care is comfort care with or without curative treatment. A lot of my patients in palliative care are still going through curative treatment, hoping for some relief from their disease process. And we'll talk about what those are in a little bit. Hospice is similar to palliative care. Maybe I'll do this. There. Hospice is similar to palliative care, but there are important differences. More than 90% of hospice care is paid for through the Medicare hospice benefit. Hospice patients must meet certain criteria, but palliative care patients do not have to meet certain criteria to be in palliative care. And on the handout at the bottom, kind of shows what hospice and palliative care has in common, and then breaks down what palliative services are versus hospice. I always think of palliative care as upstream from hospice in a patient's care. Oh, I'm sorry. Thank you. Okay, let me know if that's better. The definition of hospice is compassionate comfort care, as opposed, like I said over and over, to curative care for people facing a terminal illness with a prognosis of 6 months or less. And that's the Medicare guideline. We've had some people in hospice for just a few months. Do you need me? Oh, closer. Okay, I'm sorry. Usually I'm up walking around, so I'm not used to just standing and talking. But we've had some people on hospice, and Beth can allude to this in Brunswick County, for 9, 10. I've seen them in Nebraska on hospice for up to a year. And unfortunately, I mean, hospice does certify their patients, and so every 90 days, then 60 days, the nurses recertify them. And as long as there, unfortunately, is a decline, a weight loss, increased pain, they submit that, and Medicare is okay with keeping them on hospice. The definition of palliative care is compassionate comfort care that provides relief from the symptoms and physical physical, mental stress of a serious life-limiting illness. And as I said, I think of palliative as upstream from hospice. Palliative care can be pursued at diagnosis, during curative treatment and follow-up, and at the end of life. Palliative, the focus is not curing the disease. Hospice eligibility requires 2 physicians to certify that the patient has less than 6 months if the disease follows its normal course. Palliative care is begun at the discretion of the primary care physician. So your physician, would usually initiate that talk with the patient about palliative care. At palliative, we will see them at any stage of their disease. And actually, for me, it's better if we do see them earlier in the process. That way we get to know them, they get to know us. The focus is improved quality of life and reduced inpatient and emergency room visits. Can you not hear me?
No, but you say the definition of palliative care.
Palliative care is compassionate comfort care that provides relief from symptoms, physical and mental stress. So it's similar to hospice. You mean who provides it? Okay, I'm a nurse practitioner, and usually nurse practitioners, for instance, I will get an order from your physician saying, Mary Smith, I hope there's no Mary Smiths here, that Mary Smith, has end-stage dementia, and I would like palliative care to go in. Usually they signify they want me to help them in the home or in the facility with symptom management, and then to sit down and talk to that patient and family about goals of care. And at that time, we usually talk about do not resuscitate status and a most form. I don't know if you're familiar with what a most form is. Okay. So the focus, is improved quality of life. And as I said, hopefully, a lot of patients I see have been in the emergency room a lot. And so by me visiting once every week or 2, I can hopefully head off, if they're starting to be symptomatic. And then I communicate directly to the doctor and make recommendations. I think we need to do this. And like I said, hopefully that'll keep them out of harm's way. Hospice and palliative care are both interdisciplinary in that there's teamwork for both of the hospice and palliative care teams. We address physical, emotional, and spiritual pain, including a lot of worries are loss of independence and the well-being of their family and not feeling like a burden to them, to their loved ones. Hospice care costs are, there's a typo. Are there any teachers in here? Because I did have some typos in here, so I'm sorry for that. Hospice is covered at 100% by Medicare Part A, which is essentially saying we're going to try to keep that person out of the hospital. Now, of course, if something unforeseen happens in the home or the facility, a broken bone, a bleed that we can't control, then, of course, for hospice, they would discharge them so the person could go to the hospital and get fixed. Okay? A lot of private insurances are now providing reimbursement for palliative care. I never see the statistics on that. When I see a patient, I do bill. But I think over time, especially when I first started in hospice, that a lot of insurance companies see the benefit in palliative care because we're actually trying to be proactive before end of life. Hospice is the only Medicare benefit that includes drug coverage, medical equipment, 24/7 access to care for emergencies, nursing, social services, chaplain, grief groups following the death of their loved one, and then other services that the hospice team deem necessary. When I say 24/7 coverage, there's an on-call nurse for hospice, not palliative care. But if a person, because when is something going to happen? Usually at night or on the weekend. So they do have a nurse that they can call. The nurse will call them back, take care of them on the phone, or make a visit to their home to see what's going on. By comparison, palliative care costs from office visits can vary. And as I said, many insurance companies are now reimbursing, for the palliative services. Where is hospice and palliative care obtained? And it's delivered wherever the patient calls home. That can be a nursing home, a VA facility, assisted living, target populations. We start with the perinatal and neonatal population. Pediatrics, we've had some children on palliative care, some referrals from Duke, and they're not ready for hospice, but palliative care does get involved. But hospice then can admit children as well, if that's appropriate. And then, of course, the adult population, and then geriatric. I think my youngest patient now is 55, and my oldest was 101. So all disease processes are included, such as COPD, congestive heart failure, dementia, cancers, and Parkinson's disease. But that's limited. There's other chronic kidney disease. I've been seeing a lot of kidney patients. So the characteristics, or the patient who we feel should receive palliative care but not curative treatment, if the patient has limited ability to take care of themselves, if the patient has received curative treatment and is no longer benefiting from it, the patient does not qualify for an appropriate clinical trial. In the past, especially with the cancer patients, the oncologist will hear about a clinical trial that they could participate in, and some people just don't want to do that. And then, of course, those where there's evidence that no further treatments would be effective for them. So this talk is just to educate between what is hospice, what is palliative care. Beth has kind of been on both sides of the as far as hospice. She's been in management, but she's also been that nurse out in that home taking care of the hospice patient. So you need to talk to your family and doctor about your goals of care and whether palliative care or hospice, at some point might improve your quality of life. Okay, I'm going to hand it over to Beth.
So I'll just recap a little bit, and sorry, I typically talk loud, so I might blow you out. So just to recap a little bit of kind of how the services go. If a patient is not receiving any services, then that patient can, after discussion with the doctor, talk about what services might be appropriate. What we see a lot is if a patient is receiving home care services, they've typically had a hospitalization for some reason, or they've been to their doctor for some reason. It could be that they've been having a lot of falls, they've been having frequent hospitalizations, and that doctor just wants them to get a little bit of help in the home. If a patient is receiving home health, then those clinicians that see that patient can be very beneficial in having those discussions with the patient about what might be the next step. If a patient is having a lot of hospitalizations, that's one of the things that our palliative nurse practitioner can do, is try to help keep that patient out of the hospital. The goal of palliative is to work with that patient's primary doctor. The palliative nurse practitioner does not in any way take over that person's care. They would simply work with the patient's primary doctor to better manage that care, and we like to say it's like another set of eyes on that patient. just monitoring what's going on. If the patient's having any problems, if the patient can't always get to the doctor's office, then the nurse practitioner is the one that can contact that doctor to say, this is what I'm seeing with this patient. I am in the home seeing that patient. This is what's going on. Maybe we could try this. Maybe we could do that. And then we can, get the palliative services started for that patient and have that other set of eyes. Now, if we've been seeing a patient for home care and palliative, because a person can have home health and palliative at the same time. But if a person reaches the point where they need to transition over to hospice, then any home health services and any palliative services would stop, and then a person would get hospice, because you can't have those services at the same time. But all of those people working together with a patient can help determine if it's time for hospice. Maybe the person has been seeking some sort of treatment for their disease process, and with palliative, that's fine. A person can be seeking curative treatment. But with hospice, a difference with palliative and hospice is that a person is not seeking any type of curative treatment. So if a patient's been getting home health and palliative, and then they decide they really don't want any more treatment, or the treatments, like Helen said, are just not beneficial anymore, then a person can easily transition over to hospice. So usually the process with any of the services is that a patient has the discussion with their doctor, because everything home health, palliative, and hospice does involves a doctor's order. So we don't ever just go out and see a patient on our own. Somebody has ordered it, and somebody is driving that boat other than us. So the process is usually that patient has seen their doctor, and after discussing it with the doctor, they decide on the appropriate services. If it's just home health, maybe the person's just had some frequent falls. They need a little therapy, something like that, that's fine. If a person has had a lot of hospitalizations and they're just really having trouble managing their care, they aren't really sure what their goals are, they don't really know which way they want to go, that's where the palliative nurse practitioner can come in and have those goals of care discussions and talk about advanced directives and just find out what that patient's wishes really are, and then we know which way to go. If that person decides that, I just really am done with treatments and running back and forth to the hospital, we have a lot of patients that say, I'm just so tired of going to the hospital. So we can try to manage that person at home. And if they don't want any sort of curative treatment, even though, typically it's the 6 months or less, like Helen said, we have had patients that have been on hospice for a very long time. So they just don't want to continue to seek curative treatment. They don't want to have to go back and forth to the doctor anymore, and that's fine. And if they outlive the 6 months, which a lot of people do because they get that team approach, and they do improve. If they get their pain under control, their symptoms are better managed, then they do sometimes improve. So, a lot of people don't like to talk about hospice because it is a little bit scary. I'm reaching that point with my own parents, and so I try to see it from both sides, and it is scary to talk about hospice, but what we see a lot is patients don't get hospice in enough time to truly benefit from the service. People will wait until it's kind of panic mode. Somebody's really had a major decline, and then all of a sudden, it's, oh my goodness, this is not good. What are we going to do? We'll do hospice. And it's better for the patient and the family to accept the services sooner than later to get the full benefits of the service. So, if you know somebody that you feel like would benefit, just have that person talk with their doctor, and that's the best person to help point them in the right direction. So with palliative, it's for patients who have chronic disease processes, like Helen said, a lot of congestive heart failure, COPD, things like that. It might be somebody that has a cancer diagnosis, but they're getting treatments and they're kind of stable right now. So palliative can be seeking curative treatment, not a problem, but when they want to transition over to hospice, that's when a person should no longer be seeking anything curative. They just want to be kept comfortable at home. Sometimes patients choose not to continue chemo and things like that because all the side effects of chemo, they don't feel like they've got as much quality of life. So they just want to stop and they want to be kept comfortable at home. So that's the difference between palliative and hospice. So does anybody have a question about any of the handouts? I think it depends on what all is going on with that patient other than the dementia. If they have other disease processes going on, what is the patient looking for? What is the patient and the family looking for?
Usually, initially, I will get them in palliative care, especially because dementia is such a long but slow, gradual disease process. So I will go in there and evaluate them and see what their level of function is. One of the sheets that we included, it looks kind of busy, but this is actually, the Medicare hospice eligibility, and I think Beth included some other handouts. For dementia, we use the palliative performance scale. Usually, then there's a FAST scale also on that sheet. And, usually for hospice, the dementia patients not eating as much, not able to feed themselves. Their ability to ambulate is gone. Their speech has slowed down. They can maybe point or make their needs known. So usually we use this, and usually it's 7C is usually then appropriate for hospice on this scale. So, and like I said, dementia is such a slow progressing disease, that most of the docs get palliative care, involved first.
The question was, do we have to have an order from a neurologist to receive palliative services
Right.
for a patient with dementia?
No, it would be the primary care doctor, because all along the disease continuum, they've gotten reports, from the neurologist. I see a lot of Parkinson's patients, so it's the same thing. The primary care doctor will have some concerns, consult with the neurologist, cardiologist, whatever specialist is involved, and then we'll get that order from usually the primary care doctor.
There are some, let me just say, there are some doctors that, a lot of the specialists that will not order certain things. They say, I'll leave that up to the patient's primary. And sometimes the specialist will be the one to order certain things, and then the primary just finds out about it. So, I think it would be a case of which provider you're talking to about what's going on with the patient and what that provider is willing to do. But I think definitely in a case where there are multiple providers involved, just, to make sure that everybody knows what's going on. Because as I'm out in the community talking with the different providers about the different services, I hear it both sides. Somebody will say, well, I didn't even know they were getting palliative. I didn't order that. Who ordered it? So it doesn't have to be a specific doctor. It's the doctor's preference, really. Some of them will order things and some of them won't. So I had cardiologists a while back that wouldn't order home health for patients. They said they would leave that up to the patient's primary. So it just depends on the provider and what they're willing to order. But it is a good idea to make sure everybody stays in the loop.
And that's why I indicated to, talk to your family physicians about it, because the specialist might say, oh, we can try this, this, and this for the patient, and has not shared that with with your doctor, with the family doctor. So that's kind of where we get into kind of a mess.
So what happens if the patient is already bedridden and can't get to their doctor? Well, that is where palliative is beneficial, because the palliative nurse practitioner actually goes to the patient's home to see the patient in the home. So that's one of the ways that palliative can be helpful to that primary physician. But now, due to COVID, a lot of providers are also doing video visits. So it would depend on that provider's preference for caring for that patient. If they get palliative involved, then the nurse practitioner is the eyeball for that, the one eyeballing that patient, and can contact the provider and do it that way, unless they would prefer to do a video visit or something. But there are ways around the patient not being able to get to the doctor. Yeah. So the question is, if somebody has a diagnosis of congestive heart failure and they have palliative services, would that palliative nurse practitioner come in and do IV Lasix to help with that, to diurese the patient? The palliative nurse practitioners are not going to do that. That would be a case where they would probably order home health and have a home health nurse come in and do that. Right, and a patient can have home health and palliative at the same time. So yeah, so the nurse practitioners are not going to do that. They're kind of like an extension of the primary doctor, where your doctor wouldn't normally do that either. They would have somebody in their office do it. So the nurse practitioner would communicate with the doctor and decide, yes, that's what needs to be done. But then one or the other would probably get home health involved. It depends. When a patient chooses hospice, whoever is giving the order for hospice can choose to continue to follow that patient or turn them over to their hospice medical director. A lot of times the doctors don't, well, I won't say a lot of times, but frequently they don't want to order the pain medications that go along with hospice. So a lot of times the doctors will say, just turn them over to the hospice medical director. But then we have some too that will say it depends on the patient. If the patient wants me to continue to follow them, I will. If they don't, it's fine to use the medical director. So that's the provider's preference on that. They do both. And it can be either or. Yeah. You were asking if a person has had a stroke and they're having difficulty feeding themselves, dressing themselves, that sort of thing, but yet they're still alert and can carry on a conversation, that sort of thing. Can they receive palliative? Okay.
Yes.
So yes, they can.
Yeah. And usually when they're discharged from the hospital, they'll be sent home with home health care. And so then I usually prefer to let home health get in there, the physical therapist to help with the walking, the occupational therapist to help with the mobility, the feeding, the bathing part of it, and then the skilled nurse. And then usually then palliative care is brought in by the physician there again, to kind of help with symptom management. Okay, and then if goals of care are not in place, then that's another thing I would address with the patient and family. So I'm sorry.
And along those same lines, talking about somebody that just needs assistance with certain things like bathing and eating and stuff like that, even after a person has worked with home health, if they're still not able to do those things, there are agencies in the county that provide PCS or personal care services, and they do the non-skilled care. Medicare considers the nurse and therapist that go into a home skilled care, but there are agencies that provide non-skilled care. So if somebody is just still not able to manage, there are places that provide an aide that will go into the home to help with specific things just like that, to help the person get a bath, get dressed, meal preparation, that sort of thing. That service is typically not covered by someone's insurance, so it's a private pay situation, or North Carolina Medicaid covers that service, and sometimes patients with VA benefits will cover the aid and attendance. But if it's just simply that somebody needs help with those type services, home health is not going to be able to do that, because home health provides skilled care. So if a person has disease processes like that, it depends on their ability to stay at home, because the palliative services are for patients who are either at home or in a facility. So if a person with issues like that, where they can't feed themselves, where they can't dress themselves, they're basically a bed-bound patient, then it would have to be decided what services are appropriate to be provided in the home. And the palliative nurse practitioner can go into the home, but that's not somebody that's going to be in there on a regular basis, like every day going in to help. Palliative can go along with other services. The palliative nurse practitioner is basically like another provider that is seeing the patient in the home. The palliative nurse practitioner is not going to do a lot of that type of hands-on care. So it just depends. If the patient's needs are beyond home care and that person is in a facility, then those types of things would be addressed by the facility staff. But if a person is at home, they still would have to have arrangements for that person, for those services to be provided. And they can receive PCS services, they can receive home health, and they can receive palliative all at the same time to meet those needs if they're choosing to stay at home. The only difference would be that those services are typically not covered by insurance. So where the home health and the palliative would be covered by insurance, the aid-only services would not be.
And I think the hospitals are really doing a good job, case management, of identifying those folks. I mean, we're seeing people live longer, they're outliving their children, their friends, that they're going home to a safe environment. And that usually means that they have a caregiver in the home. Maybe not to do 100% of the ADLs or the care, but that there is somebody in the home for them. And if there's not, I've had several recently, they don't have anybody. So then instead of sending them home, they may send them home for a short time. I get involved, but then our social workers work diligently trying to find them placement in an assisted living or long-term care facility.
It depends on the electronic record that we're dealing with, because some agencies do have access to certain electronic records, but there is a lot of communication that has to occur, a lot of phone conversations, finding out who the power of attorney is a big thing, because we can't just talk to any old body about the person's care. We have to be talking to the right person. So we have to make sure who that power of attorney is, and who we have permission to talk to and who we don't, as far as family members. But that is something that's very important, is, especially if somebody chooses hospice, the family has to be on board with that as well. It really is difficult if there are different opinions in the household. It makes it a lot harder. So, there has to be a discussion among the family members and the patient to find out, what exactly does that patient want, and everybody kind of has to be on the same page. But when it comes to talking with the doctors and stuff, we find out who all the providers are, and we talk to whoever we need to get the appropriate answers. It is. And we find that different insurances have coverage for palliative and some don't. So typically what we do is just run it. If we get an order for palliative, then we just have our billing department check it to see, because we have run across patients that we thought, I don't think that insurance does palliative, but then they run it and they find out, oh yes, they have palliative benefits. So that's the best way with that, is to just run it and check.
But we don't turn
So,
anyone down. But we don't turn anyone down.
Oh no, we don't turn anybody down. I mean, if somebody has an insurance that doesn't cover palliative, we can still go out and see that patient and provide a visit and do that assessment and find out what that patient's needs are. And we're not gonna turn anybody down just because they don't have palliative coverage. So, it might mean how many visits we can make on that patient, but we're going to provide the care that patient needs But we are finding, I know Humana, a lot of times, at which there are umpteen gazillion Humana plans, but Humana typically will cover palliative. We have found some Blue Cross policies that cover palliative. Some of them, I want to say maybe United Healthcare does not have palliative benefits. But again, we run it and check it just to make sure. So, and that's the same for for home health, it's the same. Medicare covers services. Our documentation just has to show that the services are medically necessary, and our documentation has to support that. Medicare doesn't say you can only have this many visits in this amount of time. They don't do that. We just have to show that they are medically necessary. Some of the insurance companies do dictate how many visits we can make. They review the paperwork, like if a person's coming out of a hospital, they get those records and they look at what's going on with the patient, and they will say, okay, you can have 6 visits for physical therapy, you can have 4 visits for nursing, that type of thing. But it just depends on the payer. Blue Medicare usually does a little bit of a blanket where they'll give you X number of visits for each discipline. So it just depends on the type of insurance and they are different. And there is a difference in what the insurance companies will pay for. Medicare does not pay for a nurse to go out and pre-fill a pill box for a patient or insulin syringes. North Carolina Medicaid does. So it just depends on what the service is that's needed and what the insurance companies will pay for. So that's why we have a wonderful billing department that handles all of that. So we send it to them, let them run it. They're the experts on that. So yeah, because it can get tricky. Everybody's got a Medicare replacement plan of some sort, and there are all the different policies, so it can get very confusing. Okay, well, a registered nurse can provide the hands-on care following orders by a nurse practitioner or a PA or a physician. So the nurse practitioner is one of the providers. So the nurse practitioner can give orders and suggest medications and things like that a registered nurse cannot. So when a palliative nurse practitioner goes in to see a patient, they are functioning as a provider, just like the patient's primary doctor. The registered nurse can only follow orders given by one of those providers.
Yeah. Usually when I get an order for palliative care, the doctor will send me their last notes from the visit, their medication list, so I have some knowledge of what's been going on with the patient. I call the family, I set up a time to go out and meet with them. Depending on what's going on, I will usually follow up in a couple weeks, and then as needed. But I at least see my folks usually every 3 to 4 weeks. I have the understanding with my patients and families, if there's any changes at all, of course they need to call their primary care doctor, but to also let me know, because I might be able to get into the home and see what's going on quicker than, for them to get in. And then I would call the doctor and report to him or her what's going on, okay? Yes, ma'am.
Says
it's the conversation between the patient and their doctor, and then the doctor then sends me an order, and that for palliative care, like I said, indicating what's been going on and what he wants us to do in the home for him or her.
So if a person, a patient or whatever, feels that they would be better served receiving palliative care than going to the doctor, or going to a walk-in clinic, or going to the hospital, they would bring that up with their doctor.
Right. And like Beth said earlier, I do not replace their family doctor. I just collaborate with them. Okay?
And it could be a situation where a patient is already getting home health services, and so they've already got a nurse and therapist coming in, And so those clinicians also can help initiate that. They can talk with them and say, you know, you've had 3 hospitalizations in the last 2 months, you know, and you've got these things going on, and you've been telling me that, you know, you're having a lot of issues keeping up with what's going on with you and stuff. They can have that conversation and say, what do you think about, let's talking with your doctor about palliative. And then we can call the doctor and say, you know, this is what's been going on, you know, with Mrs. Jones. What do you think about adding palliative? And then if the doctor is in agreement, they can do that. And the doctors know, the doctors are aware of the services that are out there. So, you know, if they feel like it's appropriate, then they can order that. But it just depends on what's going on with the patient. If they've already got a clinician of some sort coming in, that person is a good way of deciding that those services are appropriate. And if they don't, then having that discussion with the doctor. And usually if the doctors see that a person needs a little bit more assistance at home, they know what's out there and they can order appropriate services. We're the only company that has home health, palliative, and hospice. There are other agencies that provide palliative and hospice. I think Lower Cape Fear does palliative and hospice. Help me if I'm wrong. I don't know that Amedisys does palliative and hospice. There are several other hospice agencies, but I know we do palliative and Lower Cape Fear does palliative. So, yeah.
Nationwide?
Do what?
Nationwide?
Not nationwide. Not nationwide. We have, I mean, services are, but not those 2 agencies. But yeah, I mean, they're palliative and hospice services should be all over, provided by somebody.